Hello, my name is Mustafa and I'm a medical doctor, and this is a free, high-quality online medical resource for learning nephrology. And it's going to be a series of videos, starting with this video, which will be about the nephrotic syndrome. So the nephrotic syndrome is characterized by facial edema, as we can see in this child's face, and also characterized by proteinuria, as we can see in this urine specimen. So let's start with an overview of the nephrotic syndrome. So normally the protein molecules shouldn't be lost in urine in concentrations higher than 150 milligrams per day, meaning that the protein excretion in urine should be less than 150. And if the urine protein excretion exceeds the 150 mark, then this is called proteinuria, and it is caused by many diseases, including urinary tract infections, nephrotic syndrome, chronic kidney disease, and much more. And when the urine protein become more than 3.5 grams per day, then it is called nephrotic range proteinuria, and it is caused by nephrotic syndrome. So the nephrotic syndrome, to be called nephrotic syndrome, the proteinuria should be higher than 3.5 grams. So in nephrotic syndrome, the kidney glomerulus would have some kind of problem that make it pass the protein molecules into the urine. Normally the protein molecules would not pass, but in nephrotic syndrome, the protein molecules would pass. And the problem is exactly in the podocytes. And you remember that by the O in nephrotic is the O in podocytes. So in nephrotic syndrome, the podocytes are the problem. And here we have the glomerulus, and here we have the efferent arteriole that brings the blood into the glomerulus and out to the afferent arteriole. And the blood would be filtrated in the glomerulus, and the electrolytes and other filtered material would be passed into the Bowman capsule here and into the renal tubules. And in nephrotic syndrome, the filtration slits between the podocytes would be bigger than normal, allowing the protein molecules to pass through those filtration slits. So this is here, the podocytes are surrounding the capillaries in the glomerulus. So here is the podocyte and here is the capillary, and here the filtration slits are in bigger magnification. So what happens is that those filtration slits would be bigger than normal, allowing the protein molecules to pass, because the protein molecules are bigger than the other filtered molecules, and they pass when the filtration slits are bigger than normal. And this is the case with the nephrotic syndrome. So this slide is about the pathophysiology of the nephrotic syndrome. So the nephrotic syndrome leads to proteinuria, which is also frothy urine. And because of the protein lost in urine, this would lead to decrease the serum protein. And one of the proteins lost is the immunoglobulins. So their levels would decrease. And remember that those immunoglobulins are related to immunity. So when their levels decrease, this would make the person more susceptible to infections. Also, the coagulation and anticoagulation proteins are lost. So one of those anticoagulation factors is the antithrombin 3 factor. This factor function is to deactivate the active forms of factor 9, 10, 11, 12, and factor 2 as well. So when it is level decrease, this would lead to increase the susceptibility to coagulation, which is also thrombosis. So in response to the protein lost in urine, the liver would react by producing more proteins and lipids. And this would lead to hyperlipidemia and fatty casts in urine. So the nephrotic syndrome patient would have hyperlipidemia, fatty casts, thrombosis, and infection. And as a result of the protein lost, also the albumin is lost, because the albumin is one of the major proteins that form the serum protein. So as a result of the albumin lost from the blood, this would lead to decrease the plasma oncotic pressure. Because remember, the oncotic pressure is formed by the albumin and other proteins in the blood. The oncotic pressure keeps the blood inside the circulation. Because remember, we have the hydrostatic pressure and the oncotic pressure. The hydrostatic pressure is responsible for pumping the blood. The hydrostatic pressure is produced by the heart, and it would push the blood in the circulation. The oncotic pressure, on the other hand, is formed by the proteins, and it would keep the blood in the circulation. When the oncotic pressure is lost, this would make the blood or the fluid inside the circulation will go out to the tissues, and this would lead to the edema. And also because the fluid in the circulation is being lost out of the circulation into the tissues, this would decrease the intravascular volume. And because of that, this would lead to activation of the renin, angiotensin, aldosterone system, because there is not enough blood is reaching to the kidneys, so the kidneys would activate the RAS system in order to make the blood reach to them. And as a result of that, there would be sodium and water retention, which lead to hypertension, and also lead to sodium and water retention, as we mentioned, which lead to more edema. So again, the nephrotic syndrome would decrease the serum protein, which lead to decreasing immunoglobulins, which lead to infection, decreasing antithrombin 3, which leads to thrombosis, decreasing or making the liver produce more proteins and lipids, which leads to hyperlipidemia and fatty acids, and also decreasing the albumin level, which lead to decreasing the oncotic pressure and subsequently edema and hypertension. So due to the albumin lost in urine, the liver tries to compensate, as we mentioned, by increasing the albumin synthesis, but it fails to reach the normal albumin levels. And as a result of the protein lost in urine, the oncotic pressure decreases, which stimulate the hepatic lipoprotein synthesis, as we mentioned again, which lead to hyperlipidemia in form of hypercholesterolemia and hypertriglyceridemia. And lipid become entrapped in casts and enclosed by the plasma membrane of the degenerative renal tubular cells, which lead to oval fat body in the urine. So as a result of the hyperlipidemia, the lipid would be entrapped in casts, so you would find a lipid cast and an oval fat body in the urine examination. Now let's talk about the presentation of the nephrotic syndrome. So the patient commonly present with frothy urine, meaning increase the protein excretion in the urine. And also they present with edema, and it will be pitting type of edema, as with this example. They also present with the swelling around the eyes, which is also the periorbital edema. As with this child here, you can see that there is a swelling around the eyes, which is the periorbital edema, and there's also facial edema, as seen here. The patient might present with ascites, as seen in this example here, and also dyspnea due to pleural effusions or due to diaphragmatic compression with ascites. So basically, there might be pleural effusions because of the protein lost. It would decrease the oncotic pressure and the fluid would go into the pleural space, or it would be diaphragmatic compression with ascites. So the ascites would become bigger and they would compress the diaphragm. Also, the patient with nephrotic syndrome present with hypertension. Hyperlipidemia is very common. The serum cholesterol commonly more than 300, proteinuria, as we mentioned, hypoalbuminemia also. Anemia is also present because of the transferrin is lost in urine. This is a hand of patient with anemia in comparison with a hand of patient without anemia. There is also increased risk of infections. The patient might present to you with an infection. It's also possible. There is increased risk of thrombosis for reasons that we explained earlier. Now let's talk about the diagnosis of nephrotic syndrome. So the best initial test to send for is the urine analysis, which detects the protein lost in urine and any urinary casts. So it is very helpful to detect the protein lost. After the urine analysis is positive, you send the patient for 24-hour urine protein tests. And the normal protein excretion, as we mentioned, is less than 150, and the nephrotic range is more than 3.5 grams. You might send the patient for urine protein to creatinine ratio, which is easier to obtain than the 24-hour urine collection. You send the patient for comprehensive metabolic panel looking for hypoalbuminemia. The normal albumin should be from 3.5 to 5 grams. If it is less than 3.5, then it is hypoalbuminemia. You send the patient for renal function tests, the blood urea nitrogen and the creatinine, looking for renal dysfunction, and you send for serum electrolytes and lipid profile, looking for any changes. And the confirmatory test is the renal biopsy, looking for the exact pathology, because there is many different etiologies for the nephrotic syndrome that has to be differentiated using the renal biopsy. Now regarding treatment of the nephrotic syndrome. So the treatment include the curative treatment, which is that you treat the cause, usually with immunosuppressive therapy, and there is the supportive treatment that you treat the blood pressure strictly to under 130/80 millimeters mercury using angiotensin converting enzyme inhibitors or angiotensin receptor blockers. You treat the hyperlipidemia with the statins. You treat the edema with sodium restriction and diuretics, thrombophilia treated with anticoagulation, infections treated with antibiotics, and so on. For every symptom, you treat it. So now let's talk about the complications. So one of those is the thrombosis. So the thrombosis typically seen in more than 10 grams of proteinuria lost per day, and coagulation and anticoagulation factors are lost into the urine, as we mentioned, including the antithrombin 3. The liver tries to compensate for that by making more procoagulation factors, which make the problem worse. And the volume depletion from diuretic therapy and reduced oncotic pressure lead to hemoconcentration and increased platelet aggregation, which leads to thrombus formation and thrombosis. So basically, the antithrombin 3 lost, the volume depletion, the hemoconcentration all lead to thrombus formation. Another complication is the infection, and that is due to immunoglobulins lost in urine. So the patient becomes more susceptible to infection, and mostly with staph and streptococci bacteria. Another complication is acute renal failure due to hypovolemia, which is, remember, the fluid is shifted from the intravascular into the tissues, which lead to edema, and that made there is less intravascular fluid and less blood reaching the kidneys, which might lead to acute renal failure. Another complication is the pulmonary edema, for the same reason, because the oncotic pressure is lost and the fluid is going to the lungs, making them congested, and growth retardation in children, because those children doesn't have enough proteins for them to grow. And finally, let's talk about the etiology of the nephrotic syndrome. So we have primary glomerular diseases and we have secondary glomerular diseases that lead to nephrotic syndrome. The primary ones is that they include immune-mediated injury to the podocyte. Examples for those are the minimal change disease, the focal segmental glomerulosclerosis, the membranous nephropathy, and the membranoproliferative glomerulonephritis. And we will explain all of them separately in different videos that will come next. In the secondary glomerular diseases, those include systemic diseases that also affect the glomerulus, and examples for those would be the amyloidosis, the diabetic nephropathy, the systemic lupus erythematosus, which is also called the lupus nephritis, and those will also explain in separate videos that will come next. And with that, we reach the end of this video. Thank you guys for watching. Please make sure to like and subscribe. And if you want to support us more, you can by subscribing to the Patreon, link provided in the description of this video. Thank you for watching, and peace.